Now I invite Dr. Muhammad Aslam Nasir, consultant anesthetist, SMART Award winner from Ministry of Trade and Commerce, UK for E-Gel and V-Gel. Dr. Muhammad Aslam Nasir. Thank you.
Good afternoon, everybody. Before I set up my presentation, is somebody? Okay, here we go. I'm really humbled, really honored, and I feel very privileged to be here, especially among a lot of my friends, colleagues, especially Dr. Fauzia. Where are you, Dr. Fauzia? I don't know, I can't see her. I, in fact, dedicate this lecture to Dr. Fauzia. She was my mentor, my teacher at Al Khan University Hospital before I actually moved to UK. And whatever you see, whatever I'm going to talk about, it's all my fault. It's my, sort of things if you find anything discrepancy in that. But whatever is the positive you can take home is because of Dr. Fauzia. I disclaim that I am called to be the inventor of two devices, one in human industry and one in veterinary industry. I work with two companies, one Intersurgical and one Doxinovant. And I also chair Light for Life as a charity in UK and Pakistan. And I would like to say thank you to Madam here from IU Medical Complex. We used to have in 2005 when the earthquake hit Kashmir, we used to have a center in your institution where we actually replaced the limbs of the people who lost during the earthquake. So thank you. So I've been involved in that as well. How many of you have seen this weapon of mass destruction? Sorry. How many people know this? Probably all of you, mashallah. This is called endotracheal tube. Imagine you have come for the first day in operating theater and I hand you this endotracheal tube and say, okay, here is the endotracheal tube. You have to have this metallic instrument with which you have to find the hole, not the one which detects the food, but the air. And if you actually can put it in, fine. If you can't, then you have to find one of these, yeah? And then put that tube in. And if that doesn't go in, you might actually have to resort one of those. And if that doesn't go in, then you might have to have a camera one. Have you heard of those? I'm sure you have, yeah? But if you tell you at the same time, I've got this device, and if I open the mouth of the patient and I just actually insert, it does exactly almost, inverted commas, the same kind of a thing which you will do with that. You will think, oh my God, what the hell, I should do that other one. As bit, horrible. Anyways, in veterinary industry, we still are about 30 years back. They still hang the tubes like we used to do 30 years ago in Pakistan, hanging from the wall, collecting all the dust, bacteria, not washing them properly, and putting them back into the patient. That's what they do as well. And I'm sure most of you know how actually they intubate the smaller animals. Imagine this is a rabbit, okay? No laryngoscope, because the airway is actually very deep behind the base of the tongue. And she will keep on going, and they're half cooked till she finds the airway, and she just drops it in. And the animal goes everywhere. So that's how you achieve the intubation in a poor rabbit. Just keep watching till he actually keeps on negotiating. Imagine the delicacy of the upper airway, your larynx, and here we go. Imagine a human being you doing like that. Now look at the other technique. You listen and keep on listening the hissing sound and you just push it in. And just imagine how much trauma that tube can cause to that particular poor patient. And the traumas every one of us know, but if you have a V-gel, which is a veterinary version of I-gel, this is a cat. It goes in like that. No problem. So easy. And if you have a rabbit, similarly, you open the mouth of a rabbit and insert the device, and it takes you less than 3 seconds to insert it, and you got an airway. If you have a horse, I'm sorry, it's a bit bigger device. You just open the mouth. There is no laryngoscope in the world apart from your fiber optic to get into a horse. And that's how actually you insert a V-gel into a horse. Brother Nasir actually was talking about gastroenterology and the food area, and I'm interested not about the whole patient, but this area. This reminds me a very nice joke. I was sitting and thinking कि दो दोस्त आपस में बात कर रहे थे कि कहता है तुम कितना खाते हो, कहता है यार मैं बहुत खाता हूँ, इतना खाता हूँ बस कुछ ना पूछो, कि बस जब सांस बंद होने लगता है. दूसरा कहता है कि तुम कितना खाते हो, कहता है मैं 2 घंटे खाता हूँ, सांस आए ना आए वो अल्लाह की मर्जी. What we actually do is we don't actually let patient die. We make sure that the sans is coming and going. So this area is of lot of interest to me. I've been working on this since last at least good 20 years. And if I be honest, I honestly don't know about this area much. Probably less than 50% of the area I understand. I don't actually understand much about it, and I'm still learning. Every day I learn, more I know that I don't know. There have been a lot of devices for safety purposes been developed in endotracheal tube areas, in other areas, but we still know there is a lot of injuries happening to the larynx, to the esophagus, to the pharynx, to everywhere, from the teeth to always wherever you go. There have been many supraglottic devices developed since last at least 100 years. 100 years and probably a little bit more. These devices have come in the market and gone, but none of them have stayed really doing much good to us. Yes, they have actually changed a lot of practice. They have created a lot of safety. But how can we make it better? There are 2 types of people in the world, reasonable and unreasonable. And the world only progresses because of the unreasonable people, because they keep on complaining. No, I'm not happy with this. I'm not happy with this. I need to actually make the world better. So this area, if actually some of the anesthetists here, I know Zayed by sitting there, Dr. Fawzia was there. This is how the most of the supraglottic devices which we use in the industry work. So you're looking through the esophagus, through the trachea upwards, and the device comes in, which is one of the very popular device so far been in the market, but it buckles in front of your airway, in front of your larynx, and causes an obstruction seal, what we call it. It doesn't really give you an anatomical, physiological seal. Then another device, we call it supreme laryngeal mask, does the same kind of a thing. iGel has been created as a anatomically shaped as a mirror anatomy to the larynx. After a lot of work we have done, especially in the US. And it does not actually collapse in front of, because it's actually preformed, made out of a very, very soft material, which is 3 times softer than your tongue. And it actually does not deform in front of your tongue and does not inflate. So there have been those devices called laryngeal mask causing a lot of problems, issues, even rotating around, causing sore throats up to 70%. The biggest problem also people have been ignoring is the stomach. That there is a lot of people, more than 50% of the people actually are at the risk of aspiration, which actually we always overlook and oversee what actually happens as a occult or as a obvious regurgitation and aspiration. There have been a very big audit project in 2001 by the Difficult Airway Society and Royal College of Anesthetists, in which there were 3 million people looked at in a manner where actually the aspiration was the single commonest cause of death in anesthesia event. And they actually recommended that you should have a device which has these 4 features. And most of the anesthetists sitting here would know that you should have proper pharyngeal seal, esophageal seal, drain tube, and integral bite block. Remember, if your endotracheal tube is sitting in the larynx, your esophageal opening is open. So if the patient regurgitates, or you have a very nice a very nice surgeon who is just pushing on the stomach, it can actually bring a lot of stuff on, and it can go right around your trachea. And the nosocomial pneumonias, we know in intensive care why happens there. Started with this small concept while I was studying and looking at various devices, that why I'm having problems, why can't I have a better device, why can't it be improved? So going through a lot of sort of prototyping stage, making devices. These are the veterinary devices. It has taken a lot of toll. I've sold 3 of my houses. I spent all of my whatever I had, and I'm thankfully not still divorced. I'm still married, and nearly got there. So this has been not an easy journey, but the best work we have done is in the University of Baltimore in Pennsylvania, near Washington, where we had these devices. But the best thing was to have the cadavers. Cadavers we have in Pakistan, India, UK, everywhere are the stiff cadavers, 6 years old, 6 months old, whatever. They get about 1,700 bodies every year who are actually called fresh cadavers, embalmed, and they are actually bagged and sent into this facility, and a lot of researchers go there and do a lot of work there. So the best thing we could actually achieve from that was the neck dissection work, MRI, CT scan, radiological work, insertion, physical work, just to see how those contours can be taken from those devices and be actually perfectly manufactured to its perfect anatomy. I understand there are inter-individual variation, but in generality, you can take that kind of a view that where it will work in majority of patients. So those were actually the real areas which actually really improved the device, its functionality. If you see one of the device, which is a previous device, and the iGel, how anatomically it sits in, it does not cause the distortion of the structures in front of it. And it snugly sits in without having that inflatable element. So this is Dr. Richard Leviton, where we were actually working together. So as I said, a lot of MRI, CT scan work. And in safety profile-wise, it actually works better than sort of any other device in the market at the moment. And you can even intubate through that device. I will take another couple of minutes if you don't mind, 3 minutes probably. And you can actually use it in many different types of patients. Simply you just open the mouth of the patient, sniff in the morning air position, and the device is in. How about in cardiac arrest kind of a situation, or at a road traffic accident? In Ontario study, it's quite clear in 10-year study that the intubation at the scene was the increased risk of death. There have been a lot of issues with, sort of 1,500 patients, one patient survived in this study, a peri-hospital study. This is from Japan. One patient survived out of 363 patients. Why? What are they doing wrong? In Pakistan, if you don't do anything, patient will survive probably anyway by itself. So why we are having all this expensive stuff, sort of in ambulances? It's because the ambulance crew actually descale themselves. They don't intubate that many patients as we intubate every day as anesthesiologist. And if you actually end up with a paramedic, you have a half chance of survival as compared to having anesthesiologist, sort of on board. Similarly, iGel has been used in peri-hospital. There have been quite a few studies where iGel has been, sort of hailed as the best device so far, and is being used with a lot of, hospitals across the world, over about 100 countries in the world. This was a very big study of about 3,000 out-of-hospital cardiac arrests, where 615 patients enrolled, including iGel, LMS Supreme, and endotracheal intubation. And iGel outperformed both of them. Then the government of those areas, it's in the northwest, and Bristol and Bath and that area, they now, if you look at it, have started a cluster randomized study comparing only iGel with endotracheal tube and spending over £2 million. Not our money, it's the NHS money. And they are actually researching whether the iGel actually outperforms even the endotracheal intubation, and that can actually change the whole philosophy of the airway management for sort of resuscitation. And that's why in London ambulance service, all over UK, almost every ambulance service, if you can think of, even US, Canada, Australia, most of the ambulance service now using iGel as a standard. It also be liked by the young babies and also liked by myself. You can actually just spray the vocal cords in a difficult intubation scenario where you don't want to intubate a patient. You can actually insert the device quite easily without much of a anesthetic, and you can actually drop an endotracheal tube through iGel into the glottis. So in summary, it's an easy device to use, gives a very high seal pressures, protects against aspiration, largely ventilation of the lungs without interrupting when you are actually doing the chest compression in cardiac arrest, and it's easy for non-anesthetist as well. And we have separate resuscitation pack as well with iGel. So I really thank you for your attention and listening to my little endeavor. Thanks.
Thank you so much. iGel and VGel. This was Dr. Muhammad Aslam Nasir. Very impressive work.
Does anybody have questions?
One question only, please. Thank you so much. Okay.
Yes, brother, sir.
Sorry. I just want to ask, what is the material? And what is
It's called
energy? Yes,
It's called, yes, it's been tested. It's called SCBS, styrene, ethylene, butadiene, styrene. It's a thermoplastic elastomer, which has been tested very aggressively against any allergies, so there's no allergy. And it's not latex that patient could be allergic to it. There's no latex in it. Yeah.
How does it differ from the laryngeal mask?
It's non-inflatable, made out of a very soft material and preformed, while laryngeal masks are inflatable. So when you inflate it, when it's around the perilarynx, it can absorb nitrous oxide, carbon dioxide, and if the operation is more than few minutes, it starts actually doubling every half an hour. So by the time you actually remove the device out without deflating, it could be actually ballooned up and causes a lot of compression trauma because of that reason. So that's the reason I went away, because everything is inflatable. Your catheter, your urinary catheter, your cardiac catheter, your sort of endotracheal tubes, everything is inflatable. And everybody was telling me that, why are you going away from departing completely and you're traveling opposite direction? So my mindset was that, sort of this inflatability is a kind of a misunderstanding by everyone, except possibly me, because it actually causes that compression trauma, and that's why the patients actually have sore throat for so many days afterwards. And if it is a preformed already, and it does not absorb anything, and it's got a fixed, sort of volume, so it will not cause, and it will be patient specific, so it will not cause those problems. And alhamdulillah, the sore throat reported with eye gel is in the region of less than 3%, depending on the study. Some studies is 1%, some studies 3%. But with laryngeal mask, it's been reported up to 70%. So you can see the difference. Why? And this gives same seal pressure. It gives the same working mechanics, if not better. In many studies, it's actually outperformed most of the other devices in the market.
I've used it, eye gel, it's excellent.
Thank you, madam.
What sizing? Like, I'm amazed that, even depending on different shapes and sizes of patients.
The sizing is the biggest problem for us. If you look at the patients from Japan to UK, to Netherlands, to US, there are different shapes and forms of the patients.
Absolutely,
Yeah. So that's the problem. We had to actually, to make it as an ISO compatible and registered device, we had to put weight as a one determinant. But ideally, as a clinician, you should look at the neck of the patient, height of the patient, size, the length of the neck of the patient, mouth opening, dentition, especially the thyroid and cricoid cartilage size, to choose your device. Sometimes, especially in females, all the weight could be here. So the neck is very small. So it doesn't mean that you should use the bigger device. So I'm say 90 kilogram. I will take size 4 eye gel. If you start feeding me McDonald's morning, afternoon, lunchtime, in 6 months' time, I would be probably 150 kilogram. So my larynx and my pharynx would even get squashed rather than having a bigger device. So you will need a smaller device.
Absolutely. I mean, yeah, that's what we're doing. Yeah.
Thank you. Sorry, ma'am.
I'm sorry.
Sorry.
We are
I
getting late.
will be around.
Yeah,
I
yeah.
actually, in fact, had another meeting.
Yeah,
I
yeah.
cancelled
No,
now.
I just thought that this is very important because the impression of using an eye gel or any other laryngeal face mask for ventilation, I don't think our training allows us to use it for the ventilated patients. Only a definitive airway should be used when the patient is ventilated. So this, can you comment for people to have this clear observation that not to use eye gels
Yes, I will be very brief.
laryngeal masks?
I will be very brief. If you look at the studies in a controlled ventilation environment, there have been many studies. If you look at some literature, just Google it. You will find many studies done with eye gel, especially in patients with laparoscopic surgeries, head down positions, and it performs absolutely fine, no problem with ventilation. So just take a look. Just Google eye gel airway device and controlled ventilation. You will find it, many of them. Thank you everybody.